I'm here today at the annual Heart Rhythm Society meetings with Dr. Andrea Natale. Dr. Natale is the Executive Medical Director for the Texas Cardiac Arrhythmia Institute. And I'm here today to talk to Dr. Natale about the management, particularly with catheter ablation, of persistent atrial fibrillation. We've heard a lot, there's been a lot published in the journals about our success managing patients with paroxysmal atrial fibrillation with catheter ablation. It's certainly been the impression probably of a lot of cardiologists that the results aren't quite as good for persistent atrial fibrillation. So can you review for us what we know about the results of catheter ablation for paroxysmal and for persistent, and what the issues are with persistent atrial fibrillation and catheter ablation that physicians should know about?
Good morning, Ken. It's really a pleasure being here and discuss such a controversial sort of area in catheter ablation and atrial fibrillation. Certainly, in this field, it's very well established that for paroxysmal atrial fibrillation, catheter ablation is superior to pharmacologic therapy, to the point that we are considering ablation, especially in younger patients with no structural heart disease, as an alternative to drug therapy and as a first-line option. And obviously, I think this will require more data, which I'm sure will come up late this year or in the next few years to support this approach. But certainly there is a long record, especially in the high volume center, about safety and efficacy in this group. Things are very different when we look at the persistent group, and more so in the long-standing persistent atrial fibrillation, which are the old permanent atrial fibrillation. Those are people that, despite cardioversion and drug therapy, they stay in atrial fibrillation, and they have been in atrial fibrillation for at least a year. So in the persistent, and in the long-standing persistent, what we have learned in the last 5 to 6 years is that what could be enough for paroxysmal, which is pulmonary vein isolation, is certainly not sufficient in these two groups. And obviously, the amount of ablation that is required to suppress atrial fibrillation is certainly much more in the long-standing persistent group.
So tell me a little bit about the different strategies that have evolved. In addition, so pulmonary vein isolation is not enough. What are the different strategies that people use, and tell me a little bit about how you approach this problem?
So beyond the pulmonary vein isolation, which still remain part of the procedure, is something that we cannot ignore. People have explored additional target which consist of linear lesions, either in the mitral isthmus or in the roof, targeting specific area based on the characteristic of the electrogram, such as what we call café, which are complex electrogram characterized by very short interval and fragmented characteristic, or based on dominant frequency, try to identify the ganglion by pacing maneuver, and more recently also based on the presence of fragmented electrogram, or ignoring all of this and focusing on really targeting other triggers based on pharmacologic challenge, either with high dose of isoproterenol and adenosine. And I think in the persistent, this is probably important in more than half of the patient, and I would say maybe in all the patient with long-standing persistent. So if we don't add additional lesion or go try to target additional targets, probably in this group, just the pulmonary vein isolation might not do justice and might probably give the impression that this procedure is not effective if we just limit the ablation to the pulmonary vein.
So if you do these additional lines and cafes, what sort of success rate can you expect from patients, and how many procedures on average do most of these patients undergo?
This is a very important question. In ablation of atrial fibrillation, there are a lot of sort of factors that ultimately affect the outcome. One of them certainly is what you do. And unfortunately, another one is operator experience, the type of protocol that people use to deliver energy, which have impact on the durability of the lesion. So all of this certainly come into play in the long-term results. So even if you do sort of what it takes, if you have less experience and the quality of the lesion that you create are not good, obviously the success is going to be still limited. So because of this, I think it's difficult to generalize the result to every lab because even people that are doing using the same approach might have very different results based on the experience and the ability really to reach at every site a stable catheter positioning, which result in a durable lesion. In this respect, I think in the future technology that give us objective information on the contact between the catheter and the tissue might enable operator with less experience to achieve a closer result to the highly experienced center. And maybe tools that are less operator dependent could also do the same, such as remote navigation and catheter that deliver energy in larger area without requiring a point-by-point approach.
So I think it's fair to say that persistent atrial fibrillation still remains more difficult problem for catheter ablation. The results may require longer ablation sessions, more ablation sessions, and require a lot of experience, particularly for some of the non-pulmonary vein additional ablation that often needs to be done.
Absolutely. In our experience, typically for a paroxysmal, the RF time goes anywhere between 45 minutes to an hour, whereas in this patient, we go sometime beyond 2 hours or RF time, which means even in an experienced hand, 3 to 4 hour procedures. And the result, I think is fair. I don't want to quote just our result. I think what I think it's important to realize is how different the experience can be. And so one of the things we have seen recently in a multi-center study that we are doing in patients with heart failure and persistent AF is that across the center, the success rate after 2 procedures can go from 30% to close to 70%. So this is an example of how variable the result can be. And those are all centers that are following a similar protocol. So I think success can be achieved, but we need technology that is going to be able to have a more uniform result across the center, irregardless of the experience of the person that does the procedure.
Well, thank you very much for joining us. That was a very nice review of catheter ablation of persistent atrial fibrillation, and I know we're going to get you back in a year or two so you can tell us a little bit more about some of the new technologies and the impact they have on these procedures. Thank you.
Thank you, Ken.